इशारा नहीं है, अगर ये हम स्लाइड लगा दें और स्ट्रीम नहीं ऑन कर दें 1:30 तक आपके फेसबुक वाले पे भी आगे से मैंने रिक्वेस्ट किया कि लाइव उसको स्टार्ट कर दें उसमें भी यूट्यूब पे, तो एटलीस्ट people will know कि 8 PM को है speech।
वालेकुम। नहीं मैं सो नहीं रहा, मैं ऊपर वो कॉन्फ्रेंस अटेंड कर रहा हूँ। अबू जी मेरी साईं ताहिर हुसैन से बात हुई थी दिन में, आप सो रहे थे। उन्होंने कहा भाई जी साइयों का प्लान है, बड़े साईं का।
अताए रब्बे करीम परचम हमारा परचम, ये प्यारा परचम हमारा अताए रब्बे करीम परचम हमारा परचम, ये प्यारा परचम हमारा अताए रब्बे करीम परचम हमारा परचम, ये प्यारा परचम हमारा
Bismillah ar-Rahman ar-Rahim. Welcome back again in our second half of the first day of the conference on the platform of giving back to pharmacy in Pakistan. I welcome Dr. Lee Shanto. Thank you so much, Dr. Lee Shan, for your precious time.
Hi, thank you for having me.
It's great pleasure, ma'am, to have you with us. So quickly moving to start our session, and first of all, I would like to congratulate the team of Giving Back to Pharmacy in Pakistan, that they have provided a tremendous opportunity to all the pharmacy leaders and pharmacists across the world on this platform to have wonderful speakers with us. And moving toward the keynote speech, we have Dr. Lee Shanto. She is an assistant professor at the Division of Pharmacy Practice and Policy. Lee Shan obtained her PhD from the University of Nottingham, and she has worked as a pharmacist in various areas, which includes tertiary hospital, general practice, and community. Lee Shan's main research goal is to be the catalyst to improve clinical practice by utilizing evidence-based research. She seeks to combine both qualitative and quantitative methodologies to inform and change practice and policy. Her area of expertise is to explore pharmacists' role in patient care, most notably in osteoporosis and Australian prescribing. Her recent research developed a pharmacist-led osteoporosis screening program in Malaysia and Australia. She has ongoing osteoporosis work in UK involving health literacy and pharmacy services. However, her latest research is in a novel field called ostropharmacy. And she is the lead pharmacy practice researcher in astropharmacy. And this project involves developing pharmacy services in space travel and understanding the human factors involved in space travel. She has funded projects with the UK Space Agency. So thank you so much, ma'am. And I'm pleased to have you with us on session. Please, you can continue.
Right, thank you for that lovely introduction, and it's nice to meet you. So I guess I will share my screen now. So is that working for everyone? Can everyone see the presentation slides?
Yeah, that's fine.
All right, so thank you for having me and taking the time to listen to my presentation. So as you know, I'm from the University of Nottingham, and I'm going to talk to you about Beyond the Horizon, Know Your Potential, and particularly focus on astropharmacy, which is what pharmacists could do or already do in space. And it is very exciting, and it's very inspirational project that I've started since I'm in the UK. So I'm trying to get the next slide, right? Okay, so I'm going to talk about the types of space tourism first, and then I'm going to talk about the types of space travelers. And I'm also going to talk about different health problems in space and the medication problems in space, the current pharmacist role in space, and the potential pharmacist role in space. So what is space tourism? So space tourism refers to an activity of traveling into space for recreational purposes. It's sometimes referred to as citizen space exploration, personal spaceflight, or commercial human spaceflight, and it covers all sorts of space flights, which include suborbital, orbital, and even beyond Earth orbit. So the very first people who have managed to do that is the Russian Space Agency, and they've sent 7 people to orbital space in the 2000s, but they ceased operation in 2010. And since then, a number of private enterprises has started to pursue space travel, resulting in various proposals. So the various kind of space tourism. So when we travel, we sort of say we go to, oh, I'm going to the US, I'm going to Australia, I'm going to Pakistan, or I'm going to Malaysia, or going to the UK. But if you were doing a space travel or space tourism, you would say that you are traveling to the suborbit. So suborbit is the one that's closest to Earth. So on the picture on the right, you can see Earth. So suborbit is the one that's closer to Earth. Lower Earth orbit is the yellowy orange bit, and that's where our International Space Station is. Then we have orbital. So orbital is beyond that, where you can go to the moon, which would take you 2 weeks. And if you wanted to go to Mars, a return trip would be, a short one would be 2 years, and a long one would be 3 years. So those are the different types of space tourism that you can go for if you have the money. Now we're going to talk about the different kinds of space tourism companies. So I've had the pleasure to visit Virgin Galactic headquarters in the US. So on the right hand, the middle picture, you can see the building. So that's a spaceport. So we have airport for airplanes, but they have spaceport for space planes. So that's the spaceport in America. And on the bottom right, the picture, you can see that that's the space plane that they use. If you look closely at that picture, you will see that it's 2 aeroplanes combined in the middle with a glider plane. And that's where the space tourists would sit. So it will sort of go up, and then they will release the glider plane, and then the space tourists will be able to see the horizon of the Earth. So that's a suborbital space flight. And when you're done with it, you land, and then you will enter their headquarters. And hopefully that video works. So you can see that guy there. As he steps on the ground, you would see that it's interactive. So the space tourists would walk on an interactive floor, making them feel like a total superstar. So this thing costs 250,000 USD if you want to go for this experience. And before this experience, you would have to go for a couple of training, and the training looks like this, which is the next video. So that's me spinning in the middle. And so on Earth, we experience 1 G of gravity. Fighter pilots, when they fly, they experience 10 G of gravity. Space tourists would experience 6 G of gravity. And what I experienced was 3 G. So it was quite nice and fun. And I really did enjoy hanging upside down, but I probably think if it was more than the 3 minutes that I did, I'd probably feel a bit nervous. So that's Virgin Galactic for you. Oops. Then we go into other space tourism companies. So we have SpaceX. So we know SpaceX has sent 2 astronauts to space with NASA lately, but they are more into orbital spaceflight. So orbital spaceflight means going to the moon. And they've had a Japanese fashion entrepreneur who has signed up for it, and he's actually looking for his girlfriend, a girlfriend to, you know, sort of say, I love you to the moon and back, so he could bring you to the moon and back. So there was this Japanese game show that he was looking for a girlfriend to bring to space. So maybe if you're interested, you can Google that up. So that's SpaceX. They want to go to the moon. Then we have Blue Origin. So Blue Origin is our Amazon guy, and they are also looking to send space tourists up, as well as commercial passengers to do mining and stuff like that. They don't use space planes. They use the conventional rocket that goes up. So that's Blue Origin. We also have Boeing. So they've signed a contract with NASA, and they want to take at least 1 space tourist up in each of their flights. We also have space hotels, but unfortunately, Orionspan has gone under in the beginning of the year. There are also other companies like Bigaloo, but we haven't heard anything from them. But it would have been so amazing if we could have a space hotel, and that view that looks really, really nice. So people are thinking about it, and, you know, just figuring out how we're going to get to a space hotel. So we have other space travelers. So we talk about space tourists. Then we used to have, you know, we still have, and we started off with astronauts. So we also then have commercial workers. So people are hoping to mine minerals or do stuff on the moon and Mars. So engineers and miners would start to go up. Normally, astronauts who go up in space, they could be, you know, they are fit, they are well-trained. But, you know, these space tourists, they are normally people that are older and richer. So that probably means that they have more comorbidities, and that means that they could be taking a cocktail of medications. So with space tourists becoming closer to becoming a reality for the average person, with this increased access to space tourism, the potential space tourists could have a variety of medical conditions and be taking a variety of medications. So pharmacists are an integral part of the patient's healthcare, dramatically reducing medication error within the first 24 hours of hospitalization. So I guess most of us here are pharmacists, so I don't need to tell you how awesome our role is, but, you know, we can do something for space travel, because currently there have been discussions of the roles of the doctors, the anesthesiologists, the physiologists, surgeons in space tourism, but the conversation for the pharmacist's role is minimal to nil. Therefore, as a pharmacist, I strongly believe, and, you know, that research on the role of the pharmacist in space is timely to mitigate the health risks and, you know, potentially saving millions of dollars and the reputation of space travel. So we need pharmacists now more than ever. I'm now going to talk about some of the main health problems in space. So there are loads, and these are just a really common one. So this might look a little bit upsetting because the picture's upside down. So living and working within the International Space Station, it's topsy-turvy, you know, the world where up and down queues are all mixed up. So when people go up into space, many will immediately get space sickness. I'm not sure if you're familiar with David Bowie, so a little bit of British culture for you. He has this song called Space Oddity. And Major Tom, so his lyrics goes, Major Tom is now sitting in a tin can far above the world, floating in the most peculiar way. So unfortunately, floating in the most peculiar way is likely to induce nausea. So in Earth gravity, we use our ear liquid to balance. So with the gravity, it can balance, so it stays there. But in space, there's not much gravity, so your liquids float around in your ear. Then your ear gives a different signal from your eye to your brain. So you get confused, then you get dizzy. So 60 to 80% of astronauts actually feel this space sickness. Scientists think it's similar to car sickness. So that's one of the very common space problems that we have. And what they have done with is to try to combat that using anti-nausea medication. They first started with cyclizine. However, about 10% of the astronauts get drowsy. And that doesn't sound like a lot, but if you're in space, an error could be fatal for you or your whole crew. So then they tried hyoscine and dexamphetamines. They used hyoscine, but they tried to counter the drowsy effect by using dexamphetamines. But now, although we have a lot of new antiemetics, it is thought that it's better to let the astronaut recover within 2 or 3 days because it is self-limiting rather than risk getting the drowsy effect. They do still use transdermal patch for diamond hydrogenate if they're going on spacewalks or if they're landing or launching. So this is because if you're wearing your spacesuit, it's disgusting wanting to puke inside your spacesuit, but it's also fatal to puke inside your spacesuit. So for precautionary purposes, they do use the transdermal patch. They've also tried intramuscular promethazine. However, the side effect of urinary retention has caused them to, they have to insert catheters during a space flight. So that's not ideal also, but those are just some of the options that they have used. So other main space health problems are related to weightlessness and its effect. So as you know, we lose the gravity, the one gravity of Earth, and it's kind of like micro or zero gravity over there. So that means that you float around feeling like a feather. So the astronauts have shoes like Velcro so that they can stick around the walls of the space station. But with that, we lose the mechanical force on our spines and our bones and our muscle, so they deteriorate. Astronauts lose about 1% of bone mineral density per month. And if you compare this with elderly women and men, they lose 1 to 1.5% per year. So that's a very big difference of loss. And they need to take a couple of years to rehab when they come back to Earth. And it's not even sure if it's a full recovery. With losing bone, that means you have a lot of calcium. So that means you are at risk of kidney stones as well. So you lose bone, you lose muscle. So what can you do? So you do exercises on the space station. You try to get your nutrients of vitamin D because you can't just go around and take a walk out. Now like it's sunny out here in the UK, so I can go and take a walk. You can't do that in the space station. So these are the problems that astronauts face and what can they do about it. So they've started with biphosphonates and exercise. So as pharmacists, we know biphosphonates slow the rate that the bone is broken down in the body. And it reduces so it maintains your bone density and reduce your risk of broken bone. When astronauts tried this together with exercise, 2 out of the 10 crew member in that trial, during that space flight, got GI problems, and it led them to stopping of the biphosphonates. So, could we have given it in an alternative way? Maybe we could give it IV, or maybe we could use denosumab or teriparatide. They've not tried it, so there's room for pharmacists to make suggestions to say that maybe we should try this. And it gets more complicated. So we've seen how the physiology of our body changes, but our pharmacokinetic, so our absorption, distribution, metabolism, excretion changes, and our pharmacodynamic also changes. So one classic example here is the absorption of our simple paracetamol. So you can see here from the picture that the graph in day 3 is the absorption of paracetamol is double, but in day 4 it's half. So it's really difficult to predict medications, how they're going to react in the body. And this is just paracetamol. What if the space tourist is on warfarin or theophylline or an anti-epileptic? So a lot of questions that pharmacists need to figure out. And I could go on and on about the different types of health problems and medications that are used in space, but this is just a summary of it. So they do take antihistamines, they do take sleeping pills, their circadian rhythm is disrupted, and there are astronauts who are allergic to moon dust. They get headaches, they get stuffy nose, as you know, they get space sickness. So these are some of the medications that they take. And to complicate things more, the medication stability itself, so the expiry date becomes less. So 87% of those medications flown in space, their shelf life is less than 24 months. And a study, an opportunistic study of 550 days found that aspirin, ibuprofen, loratadine, zolpidem has degradation. And even the antibiotics degraded, and augmentin was one of the most unstable ones. Imipenem and cilastatin was found to be okay, but maybe it's because they fly in their original package. So we don't have definite data to why this is happening. Could it be radiation? Could it be microgravity? We are not sure. So what do the current pharmacists do? Is there a pharmacist related to space travel? So yes, we do have one. So she's in NASA and she started in 2003. She basically made the job for herself and she's an amazing and very determined person. So she has a small team now, but her role was said to be mainly educating people on the pharmacist role because they quite often don't know what the pharmacist can bring to the table. And you're not convincing doctors or nurses, you're convincing project managers, you're convincing engineers and people like that. So the awareness of the pharmacist role definitely needs to be created. Her other role involves looking at metrics, so such as budget. So she thinks that pharmacists should be more proactive in space travel. And what she looks after quite a lot is actually the ISS medication kit. So in the ISS, they have a medication kit of about 190 medications. And they are divided into convenience and contingency medicine. So convenience is more for something that you can take. You're not very ill, so you can take it. Contingency is something for an emergency. And things to consider in the ISS medication kit would be the size, the need, and so you don't have much space on the space station. So you have to be very careful what you put inside that bag. And they can resupply it now every 6 months. But if you're going to Mars, you're not going to be able to resupply every 6 months. So what happened with all the expiry dates? We don't have a solution for that. Maybe you can find a solution for that. So the potential pharmacist role. So these data come from the research that I'm doing. So these are ideas that people say that we might need. And it comes from space experts, from space tourists, from pharmacists, from policymakers, and from space agency. So their thoughts on what the pharmacist could assist in space exploration is like having a pain pharmacist. So they think that it's a specialty that pharmacists can do. If you have a pain pharmacist, why not have an astropharmacy specialist? So a pharmacist specialized in space tourism, because now there's only a couple of pharmacists in the US, but space exploration is a global thing. So what are we doing as pharmacists? They also think that, we have travel BNF. So, the British National Formulary, that tick book with all the information about the drug. In Australia, you have the AMH. In Malaysia, you have the MIMS. Not sure what you have in Pakistan, but so they wanted one that could have information on space medications and how they work. They also thought that telepharmacy would be useful. So not necessarily the pharmacist needs to go out because it's expensive. So maybe we could do telepharmacy service. We already deliver remote service to Antarctica. Why not deliver it to space? And lastly, they really think that pharmacists just really need to be proactive. So to be proactive about our role, what we could bring to the table, and to do research. So people target to go to Mars in 2024. That's a bit optimistic, but who knows? So if you go to Mars, again, we have to think about what pharmacists can bring to providing medication kits. expiry, what would we need for a longer term space exploration, how are the diseases or disorders that might arise later in life with all those microgravity and stuff like that, and how would our body react to these diseases and to the side effect of our medications. So if colonization occurs, lots of humans are going to go to Mars. Can we open a Martian pharmacy? Do we need that? Do we need to manufacture medications in Mars, because you can't be bringing everything? So these are so many opportunities that you as a future pharmacist or anybody who's keen can be thinking about. And at the University of Nottingham, I do the practice lead of the pharmacy side of research, but we have a whole team of researchers doing all sorts of other research pertaining to space. So we have some doing bacteria and immunological work in spaceflight. So there is a huge bacteria get more powerful, viruses get more strong, and our immune system get weaker in space. So there are people looking at that. There's also people looking into antibacterial therapy, sending satellites up to space, looking at 3D printing medications in space, looking at how muscle works in space. And we also have a group working on how food could taste better in space. So this is a quote from one of the funders of the first commercial airline. So when I say commercial airline, it refers to things like AirAsia, British Airways. So he was one of the first funders. And that time, none of us flew. So he was saying that what was impossible yesterday is an accomplishment today, while tomorrow heralds the unbelievable. So maybe you could be the first astro pharmacy. So could it be you? And I'd just like to give a special thanks to the people who have supported and mentored me in my research and whatever I do. And so my email is at the bottom right. And I guess that's the end of the presentation. And thank you for listening to me, and let me know if you have any questions.
Thank you so much, Dr. Nishan. It was very informative session indeed, and we learned a lot about the new field, the new horizon of the pharmacy. It is the astropharmacy. So thank you so much for joining us and for giving us the knowledge and the experiences you have. And, moving towards the next session, we have the moderator with us, Dr. Samia Jamil. Can you hear me?
Yes, Assalamu alaikum.
Ma'am, you can carry on.
Can we also announce that we will be in parallel having sessions starting at 14:30 or 3:30 at the other location, please?
Yes, we have the other room for Facebook Live is open now, and some presentations will be on that room also as scheduled. And from here on YouTube Live, Dr. Samia will carry on. Please, Dr. Samia.
Thank you, Dr. David. In the name of Allah, the most gracious, the most merciful. Assalamu alaikum to all listeners and viewers of this session. On behalf of Giving Back to Pharmacy in Pakistan, I, Samia Jamil, graduate of University of Karachi and currently working as clinical pharmacist, welcome all the participants in today's leadership session of First Virtual International Pharmacy Conference of Pakistan. I hope that you all will get maximum benefit and learning from this session. Now, moving towards our session, which is preparing next generation of pharmacy leaders. Our guest speaker for this session is Dr. Umar Akhlaq Bhutta. Dr. Bhutta has done B.Pharm and MPhil in pharmaceutics from University of Punjab. He has also done Masters in Health Administration from Punjab University and Diploma in Healthcare Management from PIMS Lahore. Dr. Bhutta is also a PhD scholar of University of Punjab. He has been associated with Shaukat Khanum Memorial Hospital since 2001. He is currently working as Associate Director and Head of Pharmacy in Shaukat Khanum Memorial Hospital. Now I would like to hand over this session to Dr. Bhutta to enlighten us with the knowledge of leadership. Over to you, Dr.
So,
Bhutta.
thank you very much, Samia Jamil. Let me share my slides. So, I hope you can see the slides now.
Yes, it's visible.
Okay, thank you very much. Thank you once again. I'm really grateful for the giving back to pharmacy to Pakistan for giving us an opportunity to discuss one of the very innovative topics which were full of learning. I recently learned a lot from Miss Lee Xian, and it was entirely a different session. As per my perspective, it's quite informative for me. So moving towards the preparing next generation of the pharmacy leaders, the topic comes into our mind because that's the need of the day. And we believe that the country like Pakistan, where the pharmacy profession is struggling, the pharmacy profession is fighting and developing their roles, and they are moving in a very good speed. And we are very much hopeful that the profession will grow in upcoming few years. And we need a leaders that can run this profession in a better way, in a more visionary way. So we will just go through that, how we can go through from this one. So we all want to be successful in life. So we can ask ourselves, we would love to live like a leader, or we would love to live like a follower. So this is a question coming into mind, and you people can ask this question from yourself. So few of them will think about that they are the followers, and the few of them thinking about that they're the leaders or they're the future leaders. So we are talking about the future leaders right now. Usually followers are just following the instructions, and they pass their life with that because they don't take comes out of that box. So we will discuss, we want the new generations to be to take an opportunity and come out of the box and make an a leader. And we will discuss what's a basically leadership process is. Disclosure, I have no actual potential conflict of interest in relation to this program presentation. Pictures used in presentations are purely for educational purpose only. So leadership is not about the next election. It's about the next generation. So I repeat again this one, leadership is not about the next elections. Unfortunately, the scenario in which the pharmacy profession is working within the country is more towards like an election. The personnel who is elected is a leader of that profession. Instead, we are not talking about the new generations. We are not talking about the new skill set the people do have. We are not talking about the gold mines we have. We are talking about what we are now and what we occupy the things. We should make an examples, and we should make a space for the upcoming generations that can be a part of a success of this profession in upcoming year within the country. So once again, talk about yourself. Are you a leader? Take an honest opinion. Yes, no, maybe, not sure, possible. And all of things are possible. Every situation makes you a leader. If you're a leader already, leader, make or produce more leaders. If you are not a leader, think about why you are not a leader. You can maybe think about why you are not a leader. Not sure. That means you still not explore yourself. Possible. When possible? What will be the timeline when you will become a leader? So think on every grounds, and we should think about this one. So let's little bit discuss about the meanings of leadership. The few people said the leadership is an influence, that's it. Nothing more, nothing less. The behavior of individual directing the activities of a group towards a shared goal, that's a leadership. Not sure. The process of influencing the activities of an organized group towards goal achievement, is that a leadership? A process of giving purpose to collective effort and causing willing effort to be expected to achieve a purpose. The last definition most attracts me. Leadership is about making others better as a result of your presence and making sure that the impact lasts in your absence. That's the beauty of a leadership. That you make change, you make something, you make a beneficiary for others, make changes life of others. Let's see how we can improve this one. Leadership philosophy. Leadership is not a position or a title. Believe me, we believe, unfortunately, the dilemma of the society within country, that we believe that it's a title, it's an action, it's not an example. But that's the requirement. It's an action and it's an example. Leadership is a way of thinking, a way of acting, and most importantly, a way of communicating. The function of leadership is to produce more leaders, not more followers. I'm talking about the new generation right now. You have to become a leader, and you have to make leaders instead of followers. It's a quick slide that shows that what are the functions of a leadership. Leaderships involve the guidance, solutions, vision, teamwork, direction, strategy, communication, and goals. I've gotten a lot of opportunity to interact with the new generation pharmacists. Got a chance to meet a lot of new generation in various universities, various practice places, and they always ask that they have a lack of a leadership concept with them. They need a guidance, they need some quick solutions, they need some visionary people. They think that teamwork is a waste. They ask, they don't get any directions, don't know strategically their sound, communication, they are lacking with that, and no goals. So we need to think about leadership concept within this new generation. I've asked a few of the students, just give me the idea. What do you think? What's in a leadership? Somebody said it's an influence. Somebody says it's in a visionary. You said integrity, inspiration, charisma, courage, passion, empowerment. So you name it, and people think like that. So we have to collect and correct their thinking. That's what's actually leadership is required, and how this new generation can make it changeable. So types of leaders, we learned that leaders are by position achieved. Either if you are in a very good position, then you are a leader. Not sure. Leaders by personality, charisma. He's very good looking person. Whatsoever he's saying, you say, okay, that's fine. We will just follow you. It's a charismatic personality, nothing more, nothing less. Leader by moral example. Leader by power held, intellectual leader, and leader because of ability to accomplish things. Currently, what I feel, being a pharmacy profession, we need leaders that ability to accomplish things. Leadership in pharmacy. A lack of leadership will mean that healthcare system pharmacy will no longer be in a position to enhance patient safety, to optimize medication therapies across the continuum of care, to make a real difference in lives of the patients that we serve. So you can see why leadership is important in pharmacy profession, because enhance the patient safety is the ultimate goal of every pharmacist who is practicing in a healthcare system. Let's just go through a few challenging that we face with the leadership challenge, and that's belongs to changing pharmacy practice. Unfortunately, situation in Pakistan, we have in a weak healthcare system with a limited budget capacity. Obviously, GDP, we are not spending a lot of things on the healthcare system. Pharmacy is on the brink of an impending leadership crisis and the lack of young leaders. We can't see a young leaders. Unfortunately, we saw people who make some positions and now they are representing as in a leadership. We have a professional responsibility to deliver care to our patients. We should think about patients. Whatsoever we are planning, that should be around the patients. Lack of strong leadership causes disengagement of members, making change even more difficult. Believe me, this is the most, you can say the punchline of this slide, that whatsoever I feel with the new generation, that they are in disarrangements because they are not following the right leadership. They're confused. One of the major challenges is in changing pharmacy practice is a widespread basis that pharmacy profession is diverse. We have in multiple options. We have in academics. We have in hospital settings. We have in clinical settings. We have in industry. We have in a marketing. You name it, in pharmacy profession. Now we are talking about space as well. So that's one of the challenges as well. Old Drug Act regulations, the role of pharmacy council, which need to be triggered down, uh, which need to be more towards the focusing on the developing of the human resource that we do have in the country. Pharmacy practice opportunities challenges. We have a very limited opportunities, and once that opportunities comes, that's not um, linked with the futuristic approach. That's not linked with the leadership approach. That's not linked with the human resource that comes up with a couple of years within a gold skills they do have. Lack of structure practice training program. This is the most, you can say, critical thing that we are lacking. So we have any training programs, but they are not structured, unfortunately, like pharmacy residency programs. Multiple institutions are just getting the residencies, but they are not technically structured one. How do you feel about non-pharmacists leading our profession? We can see a lot of space, lot of positions where the pharmacist work is done by some other healthcare professionals. So how you get in a chance to become a leadership role of the pharmacy, especially if you are talking about the next generation leadership. As I've said earlier, that healthcare system leadership as just a patient-centered approach. You can see multiple functions that links with the that's required the leadership criteria, but that is around the patient-centered approach. So coming towards the next generation leaders, practical tip to get there. This is I'm talking about again for the generation who's about to come into the market, and they are talking about their future. They are considering about the future opportunities. They are talking about what they want to do. So if you want to be a good leader in your profession, you have to take these 4 steps. This I feel I've learned from multiple things, and this is the most suitable steps I can share with them. Step 1 is develop a plan. I'll just talk about in upcoming slides. Step 2 is get involved. Step 3 is leverage a mentor. And step 4 is build your own leadership skills. Stephen Covey, excellent personality. A lot of things we learned from him. He said, begin with the end in mind. And believe me, I personally use this quote that whenever I would like to start anything, I think about the end. To begin with the end in mind means to start with a clear understanding of your destinations. Unfortunately, we have a generation which don't think about the things. They're not clear with what they are going to do. It means to know where you are going to, so that you better understand where you are now, and so that the steps you take are always in a right direction. So planning is the most important thing to start up. So let's take step 1, develop a plan. Most of the people, most of the students, they don't have their own plans, unfortunately. They just do copy paste. One of his or her friends having an opportunity, they just follow those opportunities instead to making their own plan. So we have to counsel, we have to guide them. So your mission statement will ultimately serve as a guidance for all your habits, routine, decision, and future goals. Focus is personal, not professional, because it's linked with your traits. Think of most of important values you want to express. Try your own mission statement. Make a 1 or 2 line sentence and revisit it annually. Think about that. Whatsoever you plan, or you are on that plan, or you divert it from somewhere. See an example to live life with integrity and empathy while being a positive force in the life of others. I would like to share one personal thing. In past I got in a training from one of the trainer, and he asked a very good question from the audience. He said, once you will die, what you want to listen about yourself? So the question was very hard, and but the question is very good as well. What was your last introduction? He was a very nice man. He was very helping. He was very cunning. He was not a good man. So think about that. If you want your final last introduction, a very good, happy, charming introduction, work today, act today, plan today. So once you go into this world, the people think you in a positive way. Then you can't blame yourself that I was sorry, I got another chance, I'll do this one much better. So why not try today? So develop a plan. There are two type of plans. Everybody knows we make plans of plans, and we are with, and fortunately or unfortunately, we are very good in planning, but we are not very good in execution. So try to make a plan for a short-term plan and for a long-term plan, and make a write-up that plan. You will sometimes laugh with your plan, and you sometimes that will recall you where you want to go. So start writing, list the things that you motivate you, list your knowledge, skill, and experience. Incorporate your personal mission. Create a mind map as a guide. Start thinking of your legacy. Step 2, get involved. Involve yourself. Either you work like a volunteer, make an bridging with the pharmacy association, committees, initiatives, state affiliation, mentorship, policy and advocacy, research. So whatsoever you're liking, whatsoever you're planning, you just have to get yourself involved with that. Explore career options. Don't waste your time once you get graduated, once you get your transcript, once you get your license, and then you start thinking that where should I go? Think today to what you want to do and how you can save your time. Seek out unique internship, rotations, program, pharmacy administration, clinical management, pharmacy association. I usually talk about 10 new generation pharmacists. Where would we like to go? So 10 out of 9 says, 9 out of 10 says that I would like to go to become a clinical pharmacist. So if they are clear, so they should work on that, how to become a clinical management skill like that. Pharmacy association, informatics, medication safety, whatsoever the things where you want to do, take a training, don't waste your time. Meet pharmacists practicing in your area of your interest. This is the most helpful thing which we learn after our graduation. We waste our time while we were graduating. We never get a chance to interact with the people who are practicing, people who can guide us, who can save our time, who can save our directions. But times now, because the communication becomes very fast, and the people get chance of interaction with the multiple people. So what I feel that the next generation is good in that. Participate in pharmacy organization, advocacy of the profession, networking with colleagues and leaders. Networking is the most important thing that helps you to get your direction in a right way. Build your CV, leadership positions, local, state, national, unique experience. Try to get some rotations, internship jobs, presentations, professional involvement, volunteer. But keep remember one thing, one brick, one at a time. Don't take things that I will just go all things in a 3 months time. Try, focus by having a learning and with original skill set. Instead, you get an E certificate or a D certificate. You should focus that what actually you are getting out of that learning or the time you spend over there. Leverage a mentor. Seek out mentors, but another responsibility, be a good mentee as well. Mentors can help you to identify the end point and assist you in creating your plan. My father was used to say, Umar, there is no shortcut of experience, but having a good teacher, or having a good mentor, you can make access or you can make success within your life. And try to find an effective mentor. Don't waste your time with an idealism or charismatic mentor. Try with a person who's basically helps you while you're getting your life in a good position. Build leadership skills. This is step 4. I have 6 minutes to go, and I hope I'll just cover this one. So build the leadership skills. I'll just summarize them in a 3 basic functions. One is the clinical, general, and administrative one. So managing up, down, across, and out. This is a practical slide. Once you are in a good position, once you are taking as in a leadership role, you have to work with your upside, downside, across, and out. So for a new generation, you work what you used to call usually a multitasking, but I personally don't believe in a multitasking. But you have to you capable, you should have the potential to work 360-degree. That you have to believe that you work with your subordinate, you work with your higher authorities, you work with your peers, and you have to sometimes work just out of the box. So you can see managing across, be proactive as a team player, professional, make it trustworthy, establish trust, record a competence, dependability. So all these comes when you are talking about the managing things across. Once you're managing down, be reliable, consistent, fair, do mentor others, lead by example, provide feedback to help others. That's why I was talking about. You have to produce the leaders. Once you will become a good mentor, you'll start producing followers, which will eventually become the leaders. So managing up, that's the more strategical, technical terms where the leader roles comes in. Be familiar with the department mission, vision, strategic plan. You should be masters with your skill set. Until otherwise, you cannot come out of that. The role of leadership will be not fulfilling. Prioritize expectation and advocate for the most important. Negotiate mutual expectations. So I'll just show you this slide. I'll just not go one by one. You can see these things are helpful things which makes a good leader. For having a journal leadership skills, if you get a chance, every the skill having an individual training workshop for 3 days. That's to make a master on that. So think about communication, flexibility, ethical, humility, feedback, positivity, everything having its own importance. And believe me, without these, you cannot make your journal leadership skills polished. Then comes the clinical leadership skills. Develop people, team builder and leader, develop a project plan, use to influence to gain support, evaluate program, identify areas of uncertainty, and assist in adaptation, foster communication and collaboration. And the third one is the administrative skill, leadership skill set. That makes a lot of things because you should be a good administrative, you should be having good clinical skills, you have a good journal skills. That makes a good leader. That's the requirement to become an effective person, an influential person. So now the question comes into the mind where you can learn these skills. That's the most important thing because everything what we just discussed that is that's available and most of them is we are familiar with that. So motivation to consider residency training. So being a worker in Shaukat Khan Memorial Cancer Hospital, a leadership role is that to develop leaders. So we make a residency program back 7 to 8 years, and we work on that how we can make or produce skilled human resource that can be a leader in a shorter time. Residency produce leaders, and you want to be a more effective leader. Practice skills, learn in school, learn from top practitioners, career flexibility through board experience. We basically appreciate our staff for a board certification. Self-awareness through feedback and coaching, refine journal leadership skill like time management, communications. So pharmacy residencies, the concept of residencies was started a few years back in Pakistan, but there was not a structured pharmacy residency program till date today. So being at the Shaukat Khan Memorial Cancer Hospital, we work on that. So we work first level, that's a postgraduate year 1 PGY residency. And what we learn from that, we have a customized pharmacy residency program built by institution. Then we exaggerate, and then we make it a part of a international standard, and then we go for the ASHP accreditation residency programs in 2020. Now we are talking about the post-graduation 2-year residency program. So these two things will help to become next generation leaders. So think like you are a fresh graduate. If you done your Form D, so you have an opportunity to go for PGY1 residency or PGY2 residency after that. Or if you want to be a general practitioner and you want to be a specialty practitioner. So you have to decide yourself that where actually you want to go and how you want to be a future leader of this profession. Why a career in pharmacy administration? Opportunity to influence patient care on a larger scale. My personal interest was administration side, so I work and I try to excel myself on this area. Ability to lead important initiative to advance the pharmacist scope of practice. Ability to influence direction, funding, and implementation of the clinical program. Seek challenging and rewarding experience that can lead to growth and development of others. Make a difference in the life of our patients. That's important. Will you lead a change? We can lead the change that we believe in, or we can just position ourselves to be a force to accept the change being put on us by others. The choice is quite clear. We are going to lead the change, inshallah. So thank you very much. I'll be grateful once again for giving back pharmacy to Pakistan, to give us the opportunity to discuss on this innovative topic. So if the people have any question, they can email us, they can inbox us, they can text us, and we can reply accordingly. Thank you once again.
Thank you so much, Dr. Bhatta, for enlightening the importance of leadership in pharmacy. And certainly, pharmacy profession in Pakistan needs more leaders to uplift the profession. Now, I will hand over the session to Dr. Tahir to proceed with the next session.
Thank you, Dr. Samia and Dr. Bhutta. It was a really informative session indeed. And Dr. Bhutta was talking about the future leaders of the pharmacy and how leaders become into existence. And I would like to call upon Dr. Zoha Iqbal. She will be moderating our next session of Dr. Tariq Mansoor. Dr. Zoha Iqbal, please, you can carry on.
Bismillahirrahmanirrahim. Assalamu alaikum. On behalf of Giving Back to Pharmacy in Pakistan, a volunteer organization working to achieve vision of empowered pharmacists for better healthcare, I, Dr. Zoha Iqbal from Babai Medical University, Karachi, warmly welcome all the participants in the 26th session of the first virtual International Pharmacy Conference of Pakistan. I hope that you all will get maximum benefit and learning from this innovative opportunity of uplifting the profession in our country. Now, without any further ado, I would like to introduce our distinguished speaker and honorable guest for this session, Dr. Tariq Mansoor. Dr.
Thank you
Tariq
very
is-
much. Yes.
Sir, I would like to introduce you kindly, if you. Dr. Tariq is a senior in charge pharmacist at University Hospital Sharjah. He also serves as a clinical pharmacy instructor at College of Pharmacy at University of Sharjah, and in this role, he perceived fourth year pharmacy students. Dr. Tariq earned his BS in Pharmacy and Doctor of Pharmacy degree from University of Karachi. He is certified nutrition support pharmacist. Dr. Tariq also trained at world's leading cancer research institute and premier European Cancer Center. Dr. Tariq has expertise in TPN, in sterile IV admixture and oncology pharmacy services, and he has given numerous presentations in different conferences. The topic for today's session is calorie calculation and TPN. Over to you, Dr. Tariq. Please go ahead.
Thank you very much, respected colleagues. Assalamu alaikum. Thanks for giving me a chance today. So I'm going to give a talk on parental nutrition in neonates. I have nothing to disclose. So today's in my presentation, my objective will be including the classification of neonatal population to understand their needs. Then we'll discuss about the indication of parental nutrition, caloric requirement. We'll be discussing parental nutrition components, and also in our discussion, we will include the neonatal needs of macro and macro components, and neonatal challenges and the American Society of Parental and Enteral Nutrition recommendations. Starting with the neonatal need, to know the needs of our neonatal population, this is very, very important to understand. First, we need to do a classification of our neonatal population. We can classify our neonatal population in various ways. The neonates in the first 28 days of their life. We can also classify them as preterm versus term neonates. Preterm means less than 37 weeks of gestational age. Term neonatal means more than 37 weeks of gestational age. We can also classify them based on their size and weight as extremely low birth weight babies, very low birth weight babies, low birth weight babies that is less than 2,500 grams, that is 2.5 kilos, and medially low birth weight babies. So after the classifications, once we classify, we'll be able to identify the exact need of our neonatal population. So who need the parental nutrition? As per the American Society of Parental and Enteral Nutrition, we have to consider parental nutrition for neonates in the critical care setting, regardless of diagnosis when enteral nutrition is unable to meet energy needs. As per the American Society of Parental and Enteral recommendation, use parental nutrition for children when intestinal tract is not functional or cannot be accessed. Initiate parental nutrition within 1 to 3 days in infants and within 4 to 5 days in older children and in adolescents when it is evident that they will not tolerate oral intake for extended period of time. We can begin parental nutrition promptly after the birth in very low birth weight infants. So the key to success is to respond on time. For very small neonates, that is the extremely low birth weight or very low birth weight babies, we have to initiate the total parental nutrition soonest possible. That is just a few hours after the birth. The indication of parental nutrition includes, this is the list of indications which include the prematurity, that is the age, esophageal atresia, which means the complete blockage or obstruction of esophagus, intestinal atresia, short bowel syndrome as an absolute indication. Those patients who are with the short bowel syndrome, maybe they are going to receive the total parental nutrition for the rest of their life. Enterocutaneous fistulus, prolonged post-operative ileus, chylothorax, cystic fibrosis, which is a genetic disease, genetic disorder, intestinal pseudo-obstruction, that is the blockage or obstruction of the intestines, Crohn's disease, which is an inflammatory bowel disease. This is how the short bowel syndrome looks. If you can see, this is the whole bowel from one end to the other end. So the bowel is absolutely, the gastrointestinal tract is not available. So in this case, the total parental nutrition is absolutely indicated. And this is the atresia. You can see the misconnections. So nutrition support is applied. This is our daily, we have seen a lot of time in our neonatal care ICUs that sometimes the nutrition support is applied inappropriately. That is too little or too late in our too sick and too immature population, or sometimes it is given too much or too quickly to dramatically reverse prior prolonged period of inappropriate nutrition support, which is a wrong practice. We are very lucky in the very recent years, that is in 2019, American Society of Parental and Enteral Nutrition creates these pathways. You can go to the website. I highly recommend, where once you click any of the domain in this pathways. For example, if you are looking for the indication of parental nutrition or any kind of shortage you are suffering, and you want to know what is the Aspen guidelines, you can just click any of these and it will appear the pop-up with the window, and there you can further go in the details and you can read about this the pathways, clinical pathways as per the Aspen guidelines. So it is available for everybody. You can go to the website of Aspen, American Society of Enteral and Parental Nutrition, nutritioncare.org, and where you can access this guideline, and some of these guidelines are available for free for everyone. So you're not requiring any kind of payment in this. So the first thing in the once after the indications, once we know the total parental nutrition in units as indicated, the very first step to estimate the caloric goal. And this is very, very important to estimate caloric requirement accurately. Accuracy is the key to the success. Neonates, the neonatal patient, they require around 100 to 130 kilocalories per kg per day. Infant require 80 to 120 kilocalories per kg per day. The sicker or the smaller the child, the more they require the caloric needs. Ultimately need sufficient calories to promote weight gains, typically which is 10 to 30 grams of the weight per day. For the smallest neonates, actually calculate as gram per kilogram per day as per the Aspen guideline. After we know the nutrition, once we know the total required calorie, the second step is to know the the goal protein. What is the requirement of the protein? The dose of protein in neonate varies. It depends on the age of the patient. It depends on the weight of the patient, age of the patient, and the size of the patient. For example, in very low birth weight babies, the dose of protein is 3 to 4.5 gram per kilogram per day. Term neonate, it is 2 to 2.5 gram per kilogram per day. So that is why in the very first step, we have to classify our neonates as extremely low birth weight, very low birth weight, or medially low birth weight. So we can dose protein accurately, which is very, very important in our nutrition, in our neonatal population. So what about the nutrition, parental nutrition? We can classify the total parental nutrition component in two parts: macro components, that is larger in size, for example, dextrose, amino acids, and intravenous, and micronutrients, that is electrolyte, trace elements, vitamins, minerals, and so on. Today, we will be focusing more towards the macronutrients. So parental nutrition composition, dextrose, it composes 40 to 60% of the calories. Glucose infusion rate is the key to success when you are giving calories in terms of dextrose. Our neonatal population, they can tolerate up to 14 milligram per kilogram per minute. In Aspen, it's also recommended. It's also written 15 milligram per kilogram per minute. Fat, the total around 20 to 40% of the calories are coming from the fats, that is the lipofundin. Around, if you can give the max, if you give more than 60% of the calories from the fats, it may cause ketosis. It is very important to prevent essential fatty acid deficiency syndrome. You can start the dose of fat 0.5 gram per kilogram per day, and you can go up to, it depends on the requirement of the patients. The protein dose is based on the grams, the weight of the classification of the baby. Now, about a little bit about the protein, you can start early and aggressive. As per the Aspen guideline, we can start protein with the gold dose. In adult patient, as we know, we have to start low and go slow. For example, in adult patient, we can start 0.5 gram per kilogram per day, and we can go up to 1.5 or 2 gram per kilogram per day. But in the neonatal population, we can initiate with the gold dose, that is 3 to 3.5 kilogram per day, as it is well tolerated as per the Aspen guidelines. Amino acid is a source of energy, as well as it is a source of nitrogen for the protein synthesis, which is very important in this age group. Quality and the quantity of amino acid are essential in neonates, and the caloric value of amino acid is 4 kilocalorie per gram. Every 1 gram of amino acid will provide us 4 kilocalories. The very first day of the protein, we have something called a starter formula. Starter formula is, as we know, sometimes the babies, for example, if they're born in the middle of the night or when the pharmacies are closed, when it is not possible to produce total parental nutrition. So we have something called starter formulas. They are available, which is a combination. It is a combination of amino acid, dextrose, and it's available in the pharmacies without electrolytes and trace elements, which can be given as a starter in the beginning. Within the first few hours of the life just after the birth, and the next day the pharmacy can produce the total parental nutrition. ASPEN guidelines, as per the ASPEN recommendation, our neonates, they can tolerate proteins from the very first day of the life. We can begin with 3 grams per kilogram per day. Lipid also we can start can be given as a 3 grams per kilogram per day of the lipid immediately after the birth. It can be given also, and protein also 3 to 3.5 grams per kilogram per day. Just after the birth we can give it. As per the ASPEN recommendation, it is well tolerated. Now a little bit about the other micronutrients, that is the dextrose. Dextrose is a source of energy. Around 50 to 60% of the calories will be coming from the dextrose. Dextrose is the main source of kilocalories or the energy for the neonates. 40 to 60% of the calories will be coming from dextrose. Every 1 gram of the dextrose will provide 3.4 kilocalorie to the patients. The most important thing in dextrose is the glucose infusion rate. We can give, as we talked in our earlier slides, we can give glucose infusion rate up to 14 mg per kg per minute. But the starting point is the key to success. We can start from 4 to 6 mg per kg per minute, and we can reach up to 12 to 14 mg per kg per minute as per the tolerance. There are different ways, different formulas to calculate the glucose infusion rate. This is one of the way to calculate GIR, that is the glucose infusion rate in neonatal population. When we are giving dextrose more than the maximum dose of the dextrose, or if we are infusing dextrose more than the neonatal population can tolerate, for example, more than 15 mg per kg per minute, then it may cause hyperglycemia, sometimes, which is very, very dangerous for our babies. It may also cause increased carbon dioxide production, lipogenesis, liver steatosis. ASPEN recommendation is to start from dextrose as 4 to 8 mg per kg per minute, and we can advance every day from 1 to 3 mg per kg per minute up to maximum of 12.5 to 15 mg per kg per minute of glucose infusion rate. There are certain little bit about the lipids. It's available as 20% lipids in the pharmacies. There are certain misconceptions about the lipid, that it can increase the risk of sepsis, which is incorrect. It is also a misconception that lipid may compromise immunity. It may cause thrombocytopenia, interfere with the oxygenation. All these are misconceptions. As per the evidence-based practice, we can start lipid from the very first day of the life. Lipid is a very important source of energy. It is the most dense source of the energy. Every 1 gram of lipid can provide 10 kilocalories in the total parental nutrition, and it is low in osmolarity, which is very, very important in in pediatric or bigger childs, when osmolarity is an issue, and when the central venous access is not available when we are giving the total parental nutrition from peripherally. There are certain risk factors of hypertriglyceridemia, which include those patients who are on propofol or receiving steroid or liposomal amphotericin, these kind of medication. And there are certain disease state like liver or renal disease may cause hypertriglyceridemia. When to start parental nutrition in neonate is very, very important to understand. Very low birth weight neonates, we can start ideally within first few hours of the life. That is just after the birth, we can start total parental nutrition. Just always remember these neonates, especially extremely low birth weight and very low birth weight babies or premature babies, that they born without any kind of nutrition stores in their body. Unlike adult patients, because in adult patient we can wait for 5 to 7 days or 6 days, depending on the patient clinical situation. But in neonates, we have to start total parental nutrition soonest possible. And we can use, as I have discussed earlier, starter formula or vanilla back or base parental nutrition within the first few hours of the life. these starter TPNs are it's a very good choice. We can start total parental nutrition aggressively, and especially in very sick or very low birth weight babies, as it is very important to start it. This is some of the recommendation for the weight. We have to do the weight of the patient daily, the height, circumference, length, and so on. This is as per the ASPEN guideline. Electrolyte, this is very important to understand. We have to do the electrolyte panel for the first. We have to understand these neonates, especially the very small babies, extremely low birth weight babies. For example, if you have a baby in your hospital, 800 grams, the total amount of blood in the body is around 40 ml. Just remember before asking or sending any blood test that the total amount of blood in the baby body is 40 ml. Around every blood sample require, or every testing required 1 to 2 ml of the blood. So for example, if you are doing 4 to 5 different blood tests, it may take half of the body blood of the baby. So you have to do the blood transfusion, which is very dangerous. So try to avoid, when possible, the lab test. These are the neonatal norms in neonatal population. A higher sodium 136 to 145 is a normal. Potassium 4 to 6.2 MEQs per liter. 4 to 6 MEQs per liter is a normal in neonatal population. So these are the neonatal norms. So we have to understand it. We should not react once we saw these kind of lab values in our neonatal population. Osmolarity is a very important thing in parental nutrition, especially when we are dealing with bigger childs in children about 4 to 5 above the age of 4 to 5 years. As we know, parent osmolarity is very important, especially when we are giving total parental nutrition peripherally. As we know, an adult patient can tolerate up to a maximum of 900 milliosmoles per liter of the total parental nutrition. A pediatric patient can tolerate around 1000 milliosmoles per liter of the total parental nutrition solution, the maximum. And the neonatal patient can tolerate up to 1100 to 1200 milliosmoles per liter. And this is very important to understand when we are giving total parental nutrition. Peripherally, in central, the osmolarity is not an issue, but in peripheral total parental nutrition, osmolarity is a very important issue. We have to consider it. In osmolarity, different two of the macro component take part in the osmolarity and electrolytes, that is dextrose and amino acid. They take part in the osmolarity calculation, and also the electrolyte. We'll see in the coming slides, inshallah. So when we are giving the total parental nutrition, we have to understand the access, which kind of access is available before compounding or suggesting the total parental nutrition for our patients in neonatal population or a pediatric population. A peripheral access is available or a central venous access is available. For central venous access, the good thing is we are lucky. The good thing is the neonatal population, they require more calories, they require more dextrose and amino acid. So more amino acid and dextrose means the higher osmolar solution, which is not possible to be giving peripherally. And in this population, the good thing is the central venous access is available by birth. We can use it. So we can fulfill their needs of electrolytes and dextrose and amino acid from the very first day of the life. This is, we have to understand the central, what is the meaning of central venous catheter or central venous axis. In the central venous axis, the tip of the catheter is entering into superior vena cava. It is very important to make sure whenever we are infusing the total parental nutrition, that the tip of the catheter from which we are infusing the total parental nutrition, that it is sitting inside the superior vena cava. There is only one way to confirm the placement of the tip of the catheter in the central venous catheter, and that is the chest X-ray. As you can see in this X-ray, the tip of the catheter inside the superior vena cava, because any of such mistake may be lethal for our patient. Now, a little bit to understand how to calculate the osmolarity of parental nutrition. We can calculate the osmolarity. There are different ways to calculate. The quickest way to calculate the osmolarity is, for example, if you have a patient who is receiving total parental nutrition, dextrose, amino acid, and electrolytes and lipid. For the lipid, we are usually not recommending to calculate the osmolarity. But dextrose, there are different ways to calculate osmolarity. One of the way to calculate osmolarity of dextrose is to multiply the percentage of dextrose with 50. For example, if your patient is receiving, if the total percentage of dextrose, the final percentage of dextrose, for example, in the total parental nutrition bag is 10, then the osmolarity of the TPN will be 10 times 50, so it's 500 milliosmoles per liter. Amino acid, we calculate the osmolarity by multiplying the percentage of amino acid, the final percentage of amino acid in the TPN with 100. Electrolyte, we can calculate the osmolarity for each and every electrolyte separately, or we can add just 200 milliosmoles in the total osmolarity of dextrose and amino acid. So for an adult patient, if it is less than 900 milliosmol or till 900 milliosmol, we can give peripherally. In a pediatric patient, 1000, and neonatal patient 1100 to 1200. But if the patient is receiving total parental nutrition, which is most of the cases in neonatal population as a centrally, then osmolarity is not an issue. These are some references I highly recommend to go and read, that is in which is available in ASPEN website, American Society of Parental Care, Parental and Enteral Nutrition. I suggest you people to please to visit these resources, and this will be very helpful to you. And with this, thank you very much, and I'm open for any question and answer if there is any. Thank you very much.
Thank you so much, Dr. Tariq, for enlightening us with your knowledge, and I hope we have learned a lot from you, and thank you for taking out time for us.
Thank you very much. You are most welcome.
दवा के पानी हो तुम सब, दवा के माहिर हो तुम सब, खुदा के बाद है गर कुछ, दवा के खालिक हो तुम सब। परेशानी अगर आए दवा के बारे में कुछ भी, सब तजवीज़ लें तुमसे, काबिल इसके हो तुम सब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। अगर मिकदार से ज़्यादा पी ले दवाई तो तुम ही बतलाते हो उसको, सदेबाब उसका तब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। अगर कोई हो शामिल एक या दो चार मसलों में, दवा कब और कितनी हो बताते हो तुम इसको सब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। बहुत ही अहम सुतूं हो तुम बुनियाद सेहत में से, कोई भी माशरा न रह सके तुम बिन, यही है सच। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। खुदा का फजल हो तुम पर, किए जाओ ये नेकी तुम। क्या इंसान और क्या हैवान, सभी एहसान मन तुम पर। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। बहुत ही ख़ास पेशा है निगहबान जिसके तुम सब हो, बहुत ही ख़ास पेशा है निगहबान जिसके तुम सब हो, बढ़ाते जाओ तुम अपने नेकी में कदम तुम सब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। खुदा के बाद कर कुछ है, दवा के खालिक हो तुम सब। दवा के पानी हो तुम सब, दवा के माहिर हो तुम सब। खुदा के बाद है गर कुछ, दवा के खालिक हो तुम सब। परेशानी अगर आए दवा के बारे में कुछ भी, सब तजवीज़ लें तुमसे, काबिल इसके हो तुम सब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। अगर मिकदार से ज़्यादा कोई पी ले दवाई तो तुम ही बतलाते हो उसको, सदेबाब उसका तब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। अगर कोई हो शामिल एक या दो चार मसलों में, दवा कब और कितनी हो बताते हो तुम इसको सब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। बहुत ही अहम सुतूं हो तुम बुनियाद सेहत में से, कोई भी माशरा न रह सके तुम बिन, यही है सच। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। खुदा का फजल हो तुम पर, किए जाओ ये नेकी तुम। क्या इंसान और क्या हैवान, सभी एहसान मन तुम पर। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। बहुत ही ख़ास पेशा है निगहबान जिसके तुम सब हो। बहुत ही ख़ास पेशा है निगहबान जिसके तुम सब हो। बढ़ाते जाओ तुम अपने नेकी में कदम तुम सब। दवा के बानी हो तुम सब, दवा के माहिर हो तुम सब। खुदा के बाद कर कुछ है, दवा के खालिक हो तुम सब।
So let's
Assalamualaikum.
move on to our
Dr. Zohar,
next speaker.
you can start.
Okay, sir. Let's move on to our next speaker, which is Dr. Tariq Mansoor. Dr. Tariq Mansoor is Senior in Charge Pharmacist at University Hospital Sharjah. He also serves as
Sorry to interrupt you, Dr. Zohar.
Yes, sir.
Sorry to interrupt you, Dr. Zohar. Dr. Masood is our next speaker. Dr. Masood.
Okay, sir. Sorry. Yes. Sorry for interruption. Dr. Masood Khan. He is PharmD Gold Medalist and done MPhil in Pharmacology and is currently doing his PhD. He has worked as hospital pharmacist for 2 years and taught as a lecturer at Dow University College of Pharmacy for 3.5 years. He is currently working as a manager pharmacy operations Tobago and recently selected as a member Pharmacy Council of Sindh by Health Department Government of Sindh. He is head of student affairs in NCPP and he is a head of student and he is a founder of Talim Gar free schooling project. The topic for his presentation is Patient Record, the Road to Better Patient Experience, Adherence and Outcomes. Over to you, Dr. Masood. Please go ahead.
Assalamu alaikum. Am I audible?
Yes, sir.
So just need to know if you are running the presentation or I'll have to run myself.
Sir, you have to run yourself.
All right, thank you. Is it visible to everyone?
Yes, sir.
All right.
It is visible.
Thank you for the introduction and thank you for providing this opportunity to discuss about the patient record, especially in the community pharmacy. And just to clear that, I'll be focusing about patient records in the community pharmacy and that's true especially in the southern Pakistan, that is Sindh. The existing structure, how it is going, and how far we can go with this. So, patient records, the road to better patient adherence, experience, and outcomes. I just want to disclose that I have no financial relationship with anything, with anyone, and I will not be discussing anything related to off-label use of any drug. There are 4 points of the discussion. The first would be patient record. Most of us are already aware of this. The second would be patient record in community pharmacy. And then I'll be discussing mainly about patient record keeping in Pakistan, especially in the community pharmacy. How we are doing it, how it has been done formally, and how far it can go. Then I'll be sharing a few examples, not especially related to the topic, but related to the community pharmacy and the real life examples that we have come across. So starting with introduction to the patient records, most of us are aware that patient records, including anything and everything that is related to patient medical history. So as by the book definition, patient records are all details about the patient history, clinical findings, diagnostic test results, pre and post operative care, patient progress, patient past medication, and current medication order. It has everything related to patient. So if you talk about electronic medical records, the records are in the soft copy, and we are seeing that the electronic medical or electronic health records have every information that is available in a healthcare organization or a polyclinic that has previous records of the patient and existing medications. The records, as I said, includes multiple things which can be further divided into components of the EMR, that is components of the EMR, electronic medication records. We're saying that demographics, it includes personal information as basic as the name of the patient. Then we have different drug allergies, जिसमें आपके पास you have जी reactions and the reactions, if the reaction is a skin rash reaction or the reaction is a severe reaction. We also have medical history that includes any disease state, procedures that have been performed, surgical procedures or other interventions, and the previously prescribed medications that the patient have taken in previously or is continuously on the medications. And it also includes the current prescription that you usually get in the CPOE, computerized physician order entry procedures. In that process, you get the soft copy of the current prescribed medications. Now, if you say, first of all, community pharmacy. If we talk about community pharmacy, for today, I will be talking about the community pharmacy that has no link with any hospital or healthcare system. We are talking about a medical store in layman term that is situated in any area and that has no link with any lab, polyclinic, or hospital. When we talk about hospital, we have a vast data available and we use that to some extent. But when we talk about community pharmacy, we usually don't have any data. And in Pakistan, we even don't give a cash memo, or we call it a bill invoice on the patient name. The patient just come over the counter, he gets his medications and leave. So that is current scenario, or we can say this is the scenario for past 2 decades, and it's now gradually changing with the induction of proper community pharmacy chains. We have multiple chains that are coming across in Karachi, Pakistan. We have a better picture in Punjab and other parts of the Pakistan, but in Sindh, there is nothing like this. So patient medication records, if you talk about the developed countries, they use the data for multiple features. Same can be done here, but we have to start from the very basic. Like if I have to say this, that we need to take the name and number of the patient. Now, if you are in front of me, I have to ask, why do we have to take name and number of the patient? How can a name and number can assist in community pharmacy? I'll be discussing this in my presentation. In next few slides, I have very few slides to discuss, and I'll try to explain as much as I can explain. Now, record keeping in Pakistan, as I said, in Karachi, in Pakistan, talking about community pharmacy that is situated in a local area that has no link with any clinical facility like hospital. So I am excluding the pharmacies or outreach pharmacies that are operated by a Aga Khan system that are well established and they have links and they have the data available. I'm talking about a medical store, a community pharmacy. For instance, if you or me or anyone else want to start a pharmacy, so how he can use the data and why it is important to keep the records, even if you are operating as an individual. So this is a picture from a local medical store. A simple register, a notebook. The purpose to keep this register is to keep the patient engaged, make sure that the medications are available when the patient arrives. If I can read out for you, the top line has every 15th and 30th. That means the patient will be coming on every 15th and 30th of the month. Then there are a few information: the patient contact number, customer ID is a bit advanced term. We are seeing the contact number and the name. The shopkeeper will look at the details of this notebook. He will make sure that he have all the medications, since Mr. XYZ will be coming to pick the medication on 15th, and by doing this he ensures that he satisfies his patient, the patient do not have a bad experience, and uh, he has no loss to the business or no loss sale. How we can improve it? If you have to start with this is even, in fact, this is even good, since if you may recall, I said we don't even give a billed invoice. So if we start with this, even this can make difference. For instance, uh, talking about how we are doing it here, and again, just let me explain you. This is very basic data, very basic thing that we are doing. There are places to travel, there are a distance to travel. This is just a start of things that will eventually develop in Pakistan, inshallah, and we will have a difference in the outcomes of the patient therapy. So we are saying that take customer data, name, number, address, emergency address, XYZ, demographics. Issue him a number. As we give in hospital, we give him a medical. If you visit a good facility, you get a medical record number, and then anytime you visit again, you just have to give that medical record number or a number with which hospital has tagged your medical record. So issue him a unique customer number or medical record number. Offer him free services. At times, especially when there is nothing like this, and you ask someone, kindly give your number, they will be hesitant to give you the data. So offer them services for which they are compelled to give your number. So offer them free services. Now, I said this is just beginning, and you can go beyond and beyond and beyond. So integrating with the labs and clinics, if you develop a chain community pharmacy, you are operating a polyclinic type or a lab within your shop in shop concept, means you having a community pharmacy in which you have a lab counter. So now you get the opportunity to integrate the lab data with the medication data. So you are increasing your data pool. And being a pharmacist, we know that how important the data is. Impact of record keeping. What I discussed 3 points. I said taking patient name, customer data, that includes name, number, address, any other emergency number. The second point was issue him a medical record number or a unique customer ID number. This customer ID is tagged with this record, and wherever he comes up with that ID, you have information available. The third thing is, I said it is difficult to get the data. If you simply ask, give your number, the patient will not be giving it easily. So you offer them services, and for those free services, they will be giving you and that's actually we are doing it here. We are giving them free of services, and we ask them that we are needing your number and further details to offer you this service, and then they actually give you easily. So if you have a data, if you know the patients, you know that you have a chronic disease patients and they will be taking medications for their lifetime, you can actually record them, you can refill, you can offer them refill, and you have the data available. This is important for the patient as well as for your business. I'll be talking about both the things. So this is important. How it is important? For instance, the patient have taken medication for 15 days and then he do not come back after 15 days. You give him a reminder call that says your refill time is here, you are not here, and he tells that I have a medication available like 4 more days. So you can counsel him that you just took medications once daily and you took for 2 weeks and now you are consuming it in 3 weeks. That means that the patient is not adherent. The patient is not adherent. Here in Pakistan, there are few people that they feel like आज सर में दर्द नहीं हो रहा, there is no headache, my blood pressure is normal today, so let's skip the medication. But we know that there are physiological changes. The patients who are not chronic or who are newly diagnosed with the blood pressure or other diseases have more feeling about the disease, and gradually the body develops physiological changes, and then they that's the normal case for them. They do not actually feel that their blood pressure is actually high, and they start skipping the medication, and that can lead to severe consequences. So taking, I said, taking name and number is important. This is in fact after 3 months of the starting of the Vago or any other community chain. Back in 2018, we had a recall, a worldwide recall, and then valsartan with the carcinogenic agent. Now just tell me that somebody has taken 3 months medication or 2 months medications from you and you do not have any contact number. If you wish to recall, you cannot recall. When it is recalled, then it is important that the chain management is important. For instance, the manufacturer will be asking distributor to recall, distributor will ask the retail chain to recall, and the retail chain should ask the patient that whatever the medication you have left, you should come back and give it back to us. But if you do not have the data or the contact number available, you cannot recall the medication, and that happens in countries, in underdeveloping countries, in countries where we do not have a community pharmacy setup, where the patient is given medication is given with no bill or no record. You cannot call back. So this was the first time that we utilized. After this, we have another recall, but this was the first time that we called patients, and they were like, "Why are you calling us back?" We informed them that this medication is being recalled for your safety, and that was the time that patient realized, oh, this is important. So free services and patient records. As I said, that it is difficult to get patient name and number without offering them something. So you can offer them free blood pressure test, free sugar test, free body mass index test. Now, if you see that blood pressure device is one-time cost, again, body mass index device is one-time cost. Sugar strip may have a minimal cost that you can bear with. You will get the data, and now with this data, what we are doing, we are getting multiple diagnosis, we are getting multiple information. A lot of patient ask that we want to check blood pressure. We are not a patient, but we just want to check the blood pressure, or we just want to check blood sugar, since it's very kindly do this for us. And from that initial test, you got to know that their blood pressure or sugar is on a higher side. And being an educated person, being a pharmacist, or working at the forefront, you can guide them about that. Make a chart, go visit a doctor, make a chart, and come back to us. Get it checked at different time intervals. Before meal, if it's sugar, then before meal and after meal. And you actually get to know that they are a diabetic or they are a hypertensive patient. They have the disease, but they were unaware of it. So you get the data, you get the information, and you get the patient as well. You got the customer actually. If I am to think about the business perspective, you got a customer actually. He was not a patient, he wasn't choosing any medication, and now he is diagnosed with a chronic ailment that is going to live with him for the rest, him or her, for the rest of the life. Most importantly, you saved the life because he was unaware of the disease. He was not getting any medication for the disease, and that could have severe impact on its body, on its lifestyle modification. So you guided him, started with a name and number. For that name and number data, you offered him something free. In that something free, you offered him a free diagnosis or a quality of life check, and you got a patient as well. You saved a life as well. And that's how we can interlink a lot of things. This is also true for the patients that are diagnosed with the disease. So a lot of patients are taking medications and not visiting doctors. When you check the data, you see the prescription, you have the prescription, you see that they are taking medication, but still the range of the blood pressure or the sugar is not in the limit or in the control. As for the hypertensive patient, it should be with the treatment option. So you advise them, if it's HbA1c, if it's sugar, you advise them HbA1c, and you see in the past 3 months, 4 months history of the disease management. You offer them a better lifestyle modification, or you ask them to visit a doctor. That's how you can help them. Now, interaction monitoring. This is happening in the whole the world, but here we do not have. For instance, I have written 2 things here: fill and refills. Both are different terms, but are linked to the medication prescription. The fill means the first time the patient is coming to you. So, if we have a pharmacist who is well educated, experienced, and can actually identify interactions while looking a prescription, he can identify interactions or can monitor interactions at the time of fills. But if if the pharmacist is new or he's learning, and there are interactions they are rare interactions that are not normally known or we do not remember, then you have the data to review, to check, to use different tools and make a better refill. Make a better refill. When I say a better refill, then I mean that you can utilize the data. For instance, Mr. Masood has come to your pharmacy. He has got a prescription. He got it filled from you. You offered him a free blood pressure or blood sugar, anything else, and got his details. You saved the data, and now you know that the patient is taking blood pressure and sugar medications. He will be needing it after a month or a 15 days time. You make a record of a refill customer data, and you call him if he do not come back. In between those 15 days, what you can do is you can actually analyze the prescription. You can actually analyze each individual medication for its drug interaction, for its drug food interaction, for its counseling point. So when the patient is coming or the customer is coming for refill, you will have a better understanding. You may have a digital customized leaflet for him. You have information as may be required in the native language, Urdu, English, Hindi, whatever may be the language you may use for the patient benefit. So you make a customized leaflet based on that prescription. You give it to him. You have added a lot to the prescription, a lot of meaning to the prescription, a lot of meaning to your existence. You have justified your existence, and this will have a major impact on the customer as well. The patient will have, for instance, if a patient is taking medication but is not following a diet or is using something that is interacting with the medication, then the patient will not have the desirable outcomes. So if you just take the number, save the prescription, and then analyze it in the time and educate the patient at the time of refill, you are adding to the therapy. You are adding value to the therapy. Patient record. I initially discussed that a patient is coming to your pharmacy taking medication for 2 weeks, and then you see that he is not coming after 2 weeks. You called him and you got to know that he still have medication left with him for a week maybe. So you got to know that the patient is non-adherent. You being a healthcare educator, you being a pharmacist, frontline dealer, you will be guiding him that how important it is to take the medications. You have the data available, you can guide about the disease and the outcomes of the disease, long term and short term outcomes of the disease if not managed properly. So it's about realization. You need to make him realize that how important it is to become adherent to your therapy. This is the data I have given a reference. In last, it is saying that young people are more non-adherent to the therapy. They are more likely to take it casual. That आज बुखार नहीं हो, आज सर में दर्द नहीं हो रहा, आज ठीक हो गया होगा, आज जरूरत नहीं है मेडिकेशन की. So we see that as we grow older, we become more cautious about health. We do not take it casually. So you have the data available, and then when you start taking details, you start offering refills, and you get to know that you can make your own data about your local population. You can save the data, and obviously with the consent of the patient or the customer, you can use that data for multiple purposes, as we will be discussing in the next slide. So utilization of the community data, obviously after written consent or the verbal consent of the customer. You can use, if you have the data, for instance, I talk about basic things. The first one was name and number. The second was offering a medication record ID or the customer ID. The third was taking support of free services to offer to get the data, and utilization of that data for the refill or for the community. How we can utilize the data for community, provincial and national health programs optimization. For instance, you are offering a blood pressure service, you have a data available that is saying that A, B, C disease have certain percentage of prevalence in this country or in this city. Now, you are working in a population, and you got to know that the data is different from what you are getting from at the city level. So you got to know that your area or your XYZ Gulshan Iqbal Fla or Shah Faisal colony have certain this population that certain percentage is coming to me, and out of the percentage this much people have high blood pressure or high sugar. You can actually use that data to a broader level, and then ask provincial or national health programs to optimize the budgeting. You can rationalize the medication utilization. You are working in a community where randomly prescriptions are coming from clinics where we do not have any medication utilization. In hospitals, we all know that there is drug utilization review and medication utilization reviews that actually help in forecasting the procurement of the medication or controlling antimicrobial resistance. So if you are working in a community and you got to know that medications are not being handled properly or are being prescribed irrationally, then you can use the data and utilize that data to discuss for the betterment of the profession and the community in whole. Now, contributing to in controlling antimicrobial resistance. In Pakistan, it is pretty easy as to get a toffee from a shop. So you can get the antibiotic medication without any prescription, without any history, without being asked a single question. Or at times you actually go and ask the kaka that I have sore throat, you'll get a levofloxacin or anything like that, azithromycin. So when you are standing there, you will be making a difference. You will be contributing in controlling the antimicrobial resistance by limiting the use of these medications. You will be controlling by limiting the use of medications that have tendency for abuse. You will be controlling the use of narcotics medications. Similarly, like in the WAGO, the next step we are going to take is immunization and vaccination programs within the pharmacies. You can promote vaccination services. You can promote each and every vaccination program that is coming from the government, just like if through EPI, Extended Program for Immunization, a government body that comes up with different vaccination or immunization schedules. So you can promote them. You can simply place the standee, or you can collaborate with EPIs for this to provide the service at your community, since EPI centers are operating in the morning timing and community pharmacy is open till about late in the evening. So you can actually collaborate with them, offer them that you will be providing these services after 3 p.m. or 4 p.m. till midnight at your pharmacy, so as to reach the maximum population. Saving life at a community pharmacy. This is a real example. I talk about 3 services: free blood pressure, free sugar, free body mass index. We are talking about Johor area in Karachi. We were offering a free service, that is a free blood pressure monitoring service. The patient was a hypertensive patient. He was taking medications, but none of the medication was for controlling the rhythm of the heart. As we checked the blood pressure was quite normal, uh, a bit on the lower side, but the pulse was 34. As soon as we saw the pulse, we asked him that, are you taking any medications, any other medications that you haven't bought from us? We discussed with him, are you sleepless or something else? Are you athletic? The questions that must be asked from athlete, as if you know that you are an athlete, then you may have a better control of your heart rate and you can operate at a lower heart rate. But there was nothing relevant to that, or nothing was justifying that lower heart rate. So we immediately asked him that you should see a doctor, a cardiac specialist for this. He took that advice seriously. He went to Tabahat Hospital on the same day. He got admitted. He got a pacemaker, and then we got to know after 15 days when he visited us, he just entered the pharmacy and was praying for all of us that you have saved my life. So that is one example. We have a lot of examples of the medication reactions and ADRs that we deal daily. But all of it is possible only with the patient record and patient data, patient interaction. If we simply start dispensing the medications, we cannot contribute anything to the therapy. That's all. I have references in last slide. You can use to review the detailed documentation. Thank you. If you have any question, please feel free to ask.
Thank you, Dr. Masood. Thank you, Dr. Zoha. Can you hear me?
Yes, we can hear you.
Okay. Yes, Dr. Zoha, can you please wrap up the session?
Thank you, Dr. Masood, for enlightening us with your knowledge. I hope we have learned a lot from you. And thank you so much for your time and amazing presentation. And here I would like to officially conclude session 7 and request Dr. Omar Hafiz to kindly wrap up this session.
Thank you, Dr. Zoha. Thank you, Dr. Masood. A truly interactive, informative day with the help of our unique speaker has come to an end. Now, from the platform of Giving Back to Pharmacy in Pakistan, I want to thank all the volunteers, organizers, poster presenters, speakers, judges, scientific committee members, moderators, coordinators, and all those who give their time and blessings for the success of this event. We will see you tomorrow, inshallah, at 9 a.m. live on YouTube and Facebook channel with our keynote speaker, Dr. Professor Hamid Saeed. He is BPharm and MPhil from Punjab University, College of Pharmacy, and PhD from the University of Southern Denmark in the field of stem cell technology. So he will be the one who will start the session tomorrow and with the welcoming session tomorrow. So stay tuned and follow us for more to come. Thank you, everyone.
Thank you. Allah Hafiz.
Thank you, Allah.